All right. We know bunions are prevalent throughout the normal population, but they also occur in athletes. And everybody always says, at least here in the US, that you got to worry about surgically treating the athlete because you may end their careers. Well, Hans and his group as faculty may dispel that myth. We'll see what Hans has to say. I want to thank Novastep for sponsoring this session. And Hans, it's all yours.
Okay, thank you very much. So I would like to introduce my faculty. So yes, my faculties, I've got Peter Bock from Vienna. I got Norman Espinosa from Zurich, and Hazibullah Waizy is from Hanover. We're talking about bunions, but bunion is not only a hallux valgus. We talk about problems around the bunion of the hallux. So I will start now my introduction on, oh, that's the wrong one. My introduction on the, so hallux valgus in the athlete. This is, you are right, and hallux valgus in the athletes is a very difficult problem, because when you have a runner, you have a soccer player, and he has a bunion problem, you never can guarantee him that he will absolutely come back as he was before the surgery. So the question is, how often is there an incidence of hallux valgus in the athlete? I only found, first of all, the evidence on this topic is very low. So I found this one paper, association between hallux valgus and joint alignment in dancers. So they looked at 1,300 female dancers, and they had 226 control participants. There was a 40% bilateral bunion rate in dancers versus only 32% in the control group. And there were 7% in unilateral hallux valgus versus 1.8. And they found some predicting factors, which were age, gain of varum, and scoliosis among the dancers, and age and ankle plantar flexion in the control group, which does not give us very much evidence on the soccer player, runner, or triathlete. I found one paper, etiology and management of the hallux valgus in the athletes, and they found that internal external abnormalities of the hip and leg were some associated factors, tight hamstrings, short or tight Achilles tendon, and forefoot varum and forefoot varum were some of the associated factors for hallux valgus in the athlete. If we look now at papers looking at the results, this is one paper, modified chevron osteotomy for hallux valgus in female athletes, a 2-year follow-up study. And they found that the AF is improved as in all bunion studies. The range of motion was maintained, which is surprisingly, because the papers we did in our patient group, they had about 10% of range of motion reduction. The cosmetic result was in 95% excellent and good, and they had a significant correction of the hallux valgus intermetatarsal angle.
Hans, sorry to intervene. Are you able to show this slideshow view?
I did.
On ours, it's showing up just as your slide review, not each individual slide.
Okay. I see the slide review.
Yeah, it's in slide review versus slide.
No, I see the total slide actually.
Oh.
Okay. Or maybe, yeah. You see it now correctly?
No, it's still your slide review.
Okay.
Are you able to hit? There you go. We got it now. Yep.
Okay.
Awesome.
So now return to sports following hallux valgus correction. There was retrospective study of comparison of metatarsal shaft osteotomy were modified lapidus. And what you see here is there was a 68% return to running after metatarsal osteotomy, and a 62% returned to running after the lapidus. And there was a 81% return to running at the patient's own speed, but not the same speed compared to before surgery. So if we have to talk to our patient, informed consent, we have to tell them, maybe you will be not at the same level as you were before the surgery. So return to sports and physical activities after modified lapidus in young patients. 4 in 5 patients were able to participate in previous sports, which is 20% do not participate at the same level. And participation level or better after the modified procedure, patients were satisfied in regard to return to sport. But again, not 100% of those patients returned to their same level of activities. And this is a hallux valgus in the athlete current evidence, is a typical Nicola Marfulli study. And they found actually 5 papers, some of the one I already cited. And the most important factor is if we have athletes, you need a very sound postoperative protocol of rehabilitation, which is regardless whatever procedure you do. But if you just do the surgery and don't look specifically at the postoperative regimen, you will not have the same results and the results the patient is looking at. So these are typical custom-made running shoes for hallux valgus athlete. And with this final slide, I would hand over to Hazibullah Waizy for his presentation.
Mati, we cannot hear you.
Okay. Thanks for invitation. Thanks for giving me the time to talk about this topic, which is not, I think, not really easy to handle because we have studies, and Hans already mentioned them, but we have not a lot of studies about this topic, but it's frequent there, and we have problems with that. You can see my slides?
Yes.
Yeah.
Perfect. So we know about this. I think I should not repeat about how we measure the hallux valgus, how we measure the intermetatarsal angle. The thing in the last years, we learned a lot about hallux valgus, especially about the rotation pathology, that we have to take care of this additional pathology which is present in those cases, and we have to realign not only the AP view, we have to align the rotation. But what I think is also important is that we have a dorsoplantar instability. I would not like to talk about hallux rigidus, but we have patients with the instability of the first ray. It's this already described years before, and especially if you have in sports, these problems, you may run in trouble. You can measure it you can measure the AP view, you can measure it in a weight-bearing situation. You just circle around the head, and then you measure right at the neck the distance between the first and the second ray, and there are numbers in the literature. We did this already in a couple of big group of more than about 125 patients with hallux rigidus. What I think, in my view, was interesting to see that we have a more elevation if we have a higher grade of arthrosis. This may show us just for the hallux rigidus that elevation is not primary. We have, by developing hallux rigidus, the elevation will be more. But this is not the point what I would like to talk today about. This is a typical patient. We have a patient, it's a long distance runner. Also, he's doing a lot of boxing. And this is the pre-op presentation. We see that the first ray, the first head of the first ray is elevated. And He also has pathologies of the second and the third and the fourth ray. You can imagine how the plantar aspect looks. We have a hyperkeratosis, we have an instability of the second metatarsophalangeal joint, and the second show is overcrossing. The X-ray shows us of this patient. We don't have such a big hindfoot valgus. The talonavicular joint is well aligned. We have the elevated first ray, less weight bearing of the first ray. We have more weight bearing of the second and third. The joints are already dislocated, and especially the second one. We see the hammer-toe presentation of the lateral view. In this case, sports is, especially long distance running or boxing, is not really helpful for him. This is the pre-op presentation. He has a good range of motion, only on not weight bearing. As soon as you have a weight bearing position, the first ray is going up, and then you have the problems on the first ray, and he's trying to avoid this by going over to the second and third ray. You can do a Lapidus procedure. We heard already, this is a procedure. We know that you can do an arthrodesis of the first TMT joint, getting a plantarization, but it's already a big procedure. It's a stiffness of a one joint, which is not so useful because he's elevating the instability. But this is one procedure you can use. Another procedure what we can use is something like that. What I do usually in mild or moderate hallux rigidus cases, it's a plantarization of the first head to get rid of the bump and also realignment of the head. It's you can do it with such a angle, a dorsal chevron, something like that, to get more stability, or just in a wild technique. And this, we published this already last year and in a case series, and you can gain a lot of range of motion in those patients, and also less decompression of the joint. And on this X-ray, you can see the sliding of the head and full weight bearing afterward. This is the case where I started. And as you can see the head as well. There's no arthrosis in this head. It's a good cartilage position. We don't have a exostosis, a huge exostosis on a dorsal aspect. So a chylectomy would not be helpful for this case. What I did such a osteotomy, like a vial. And during the operation, you can shift the head as plantar as you would like to have it. Fix it with the like a chevron technique with the key wire. This is a single-use drill what I use, and then you can realign the head. And this is post-op. Okay, it's not weight bearing, but if you simulate the weight bearing, it's still, you gain plantar contact, but you gain also dorsal range. Again, back to this case, and this is the problem why they come to you. They don't come and say, oh, I'm not able to do range of motion of the first ray. It's a pain. It's a pain beneath the second and third. What the pathology behind this, we have the plantar plate, and the first, the head of the second metatarsal, the toe, and here's the plantar plate. By bringing weight bearing by time we have the rupture. If this is ruptured, we have the dorsal and the plantar rupture and the dorsal subluxation of the toe, and the head gets prominent plantar, and the pain is coming there. This is, you can set on the clock for that. And the clinical presentation like this, or we have different cases, especially for long distance runners, it's a quite problem. What we would like to have to rearrange the joint, get a better plantar aspect of the second one. We used to do a vial osteotomy. And if you do the vial osteotomy, by time those patients, they don't have only the problem of the second, they have all the third, sometimes on the fourth joint. And with the vial, it's quite invasive. We know that, and we know also the literature. If you go closer to the literature, you will see we have floating toe presentation up to 70%, and also another problems maybe in this. what is new, what has became popular in the last years is the DMMO. It's a osteotomy of the metatarsal at the metaphyseal area, where we do a minimal invasive approach. And going to this literature, to this study, it's only level 4, but it's still a study where we have to compare this. And what we see that we have in this technique, safe procedure, good clinical outcome, less stiffness. And if we compare this, the osteotomy technique with the DMMO, the vial, or the plantar plate repair, it's definitely less invasive, and especially if you have cases with the second and third ray, it's more benefit for the patient, especially for this for ours. This is all I need for that. It's a small knife, the single-use instrument for the osteotomy, and not more, no implants. If I do use implants in other osteotomy techniques, I need a little bit more. You need special burrs for that. And if you're interested, you can join. A lot of presentation will come in the next weeks, months, and years about this technique. And this is a little bit presentation how it looks in the OR. You see the laser of the X-ray and the incisions, and then you go in and cut it and elevate the head. This is another case where I did an additional Aiken osteotomy. This is the clinical presentation directly second day. Post-operative stabilization stirrups, they will get stiff if you do, if there's a bleeding afterwards, so it's not beneficial. You can use tapes or pre-cut tapes, what I like to use. Going back to that case, we have the pathology of the second, third. What I did in this case, I did an osteotomy of the second toe, stabilize the key wire. In those cases, I try to be in at least some way to stabilize the second joint and then do the osteotomy of the second metatarsal head. By that, you can reorganize this, especially if you're medial or lateral pathology. This is a post-op, 6 weeks post-op, still stiffness. It's not well aligned like a normal toe, but we have the crossover is gone. We have a plantar contact of the second toe and no arthrodesis. And especially if you look to the DMMO area, it's really good. And this is the 6 week post-op. And what we gain is in a weight-bearing situation, dorsal extension of the first metatarsophalangeal joint, and a better aligned second, third, and fourth metatarsal. I have some cases, one case to present what it's additional possible if it's the DMMO. In those cases, if you see to the medial aspect of the second, third, you can well align this. And I think we will have time to talk about MIS in the future. A lot of techniques are possible. We have a lot of literature is coming, and we will have cases to talk with the whole group. Thank you.
Hey, Hazibullah, I have a question for you from the crowd. Will the distal plantar grade osteotomy increase the risk of metatarsalgia?
Of the first ray will increase the risk? Yes, if we have a normal situation before. But we start in a pathology situation where the first ray is more elevated than we would like to have it. So if you have a normal alignment, you do a plantarization, you will have definitely more pressure on the first ray, but we start in a pathology situation.
All right. And Hans, I have one question for you. For the patients with hallux valgus and a flat foot, should the flat foot be managed simultaneously? And if so, what kind of procedure should be performed? And is an arthresis something that should be performed?
Yes, if you have a flat foot deformity, you should address if you have a hallux valgus and a flat foot, you should address the flat foot. Which technique exactly should be performed? Well, it has to be chosen according to the pathology and of the patient. And an arthresis is also an option in the adults. I don't use it so often. I do have a question for for Hazi.
Yeah.
If you said a lapidus is an option for hallux rigidus. So now you have an athlete and you already have some hallux rigidus, some joint problems in the hallux, and then you do a lapidus. But in the future, you will have then two fusions. So
yeah, what I wanted to mention it is the realignment of the first ray. There's hallux lapidus an option. It's not an option for me. I don't do that, because if you do that, you're going in trouble. This is what you would like to mention, is you have a first ray, stiff first ray. So this is there's the reason for why I do the plantar osteotomy of the first metatarsal head. I try to avoid to go for the first TMT joint in hallux rigidus.
Okay.
May I ask also a question? Oh, Peter, do you want to do the first?
Yeah, thanks, Norman. I have a question to the panel. I know this is not described, but what I thought with Hazi's case, like with an elevated first MT1, has anybody thought about doing a cotton osteotomy or not? Especially if you have like a first, if the first metatarsal is quite short and you don't want to do a shortening with wile. Has anybody thought of that?
It is exactly the point what I wanted to point to, because if you, Hazi showed all the long second metatarsals and first metatarsals. So if you have a long metatarsal, it might be reasonable to shorten it like a wile. But if you have already a shortened first metatarsal, what we did was a plantar flexing first metatarsal osteotomy. By doing so, you are not relevantly shortening the first metatarsal, but you are inclining in towards the plantar, to the floor. And we had some successes, but not in all cases. So, but this is something that I wanted to ask Hazi too. Are you always doing this shortening osteotomy? Or do you do what Peter also tried to point out? Is an alternative if you have a very short first metatarsal?
I think it's a definitely something you have to think. What I take care of is if the hindfoot valgus there. If the hindfoot valgus, I'm going more something like a cotton or a hindfoot realignment. But in this case, the hindfoot was well aligned, so I would not go for cotton if the hindfoot is well aligned. I'm a little bit frightened that you will lose the power by the instability of the TMT1. I don't have much experience. There are not so many cases in this, but this is what my view is in this. If I have a instable hindfoot, instable TN joint, I'm going more for that. Hans?
Yeah, my question is also to Peter. It's a good idea to make a cotton osteotomy, but you already have a tight MTP1 joint. So if you do a cotton, you increase the joint pressure, and then I'm a little feared about increasing also the future of the rigidus. So theoretically, a plantar flexion, a plantar closing wedge osteotomy to incline the metatarsal would be better, but I have this done only once in my life.
That's technically.
We have a series of 10 cases, and 8 were not so bad, but also not perfect. I must be honest, and it's difficult to do, but we did this.
But you did a dorsal opening wedge, Norman, or a plantar?
No, we did a plantar closing wedge.
Plantar closing, okay, right.
Yes,
near the base.
And then the plate is put on plantarly on the tension side. So it's difficult to do, and I must be honest, we did 8 were okay, but not perfect.
Also, I know that we're talking about typical bunions in our session, but I have problems with those patients. Sporty, active, no arthrosis, and an instable first ray. Is there what would you do in those cases? What is your approach?
Training of the peroneus longus.
You going for the perennials longus?
Yes, training.
Training.
Spinal dynamics training of those patients, because they need to stabilize the first ray, and the first ray will be stabilized by the perennials longus.
Okay.
But I think, the option, and I will mention that in my slide as well, that MIS, what you did for the second and third ray, I think that's a big advantage doing it MIS, especially in athletes and people who want to do sports again. I think this is like a big thing for them, not doing an open while and all this stuff. So I think this is a really good option for the future. We already have it now, but I think especially for athletes, I think that's a big step.
I think we should continue now to Norman's presentation, and we'll have a little time, hopefully, afterwards to discuss a little bit more. Norman, can you?
Yes, I try to. How do I do this? No idea. I have no idea how to
open up your PowerPoint presentation on the side, and then you have to give it free.
But I did, and it. There's popping up some windows. I have no idea what.
Well, try it, and Peter, can you start your presentation in the meanwhile?
Okay, can you see mine?
Yes.
Yes.
Yeah, okay, good. My topic is, what do we do after surgery, actually? Okay, wonderful. So how do I go on like this? Okay. And we could say, mission completed, actually. This looks really nice. I mean, the bone healing is okay. And this patient has a nice alignment. So why not say at week 5 or at week 6, this patient should go running, do any kind of sports, because we know the bone is okay. I think that's not, and I think that's not possible. Everybody who's treated sports guys, athletes knows that's not possible if there's just a bony union. That's not enough. And I ask myself from the other side, so is the hallux, is it just a wicked toe? Is it just in a malposition, or what is behind all that? And there are a lot of different studies with petabarography from with patients from that have a hallux valgus and they don't have hallux valgus. The results in literature are not really consistent, but we do see changes. The changes are sometimes different in different studies, but still, let's get through it a little bit. What we see in most of those studies is that we have reduced peak pressure under the first toe. So what happens is people cannot roll over their first toe, and they don't have like the grip on the ground with the first toe when they have a hallux valgus. That's why we have elevated pressure underneath the MT1 head and as well. And that's not very consistent in literature, but most literature also reports like what we see is the classic transfer metatarsology with MT2 and MT3. And what we also see with some papers also saw is like an elevated pressure under the heel. And another thing is, which we experience with our patients, that pain additionally can alter foot mechanics in a pathologic way, because people try to avoid the pain and then they start to do other things. So another very nice paper was this one, I think. And what they realized is that the toe flexure strength was weaker in the HV group than in the healthy group. And you had a negative correlation. So if the hallux valgus angle is bigger, the toe flexor strength is weaker. So the bigger the hallux is, the weaker is the first toe. And you had a positive correlation of the flexor strength, toe flexor strength of all the toes with the pressure underneath the MT1 to MT4, which means if the flexion of the toes, especially the first one, is weak, we have more pressure underneath the metatarsal heads. So when we say we have a hallux, it's not only the toe which is and Hans already mentioned, and Hazi showed a very nice example as well. It's not only the toe, it's the whole foot that's altered. And now we have to ask, can we just cure this problem with just shifting a little piece of bone? That's it, or how do we treat that? It seems, and that comes out with different studies, we can definitely change it for better. Well, we cannot restore an absolutely normal situation with a healthy individual. And what we have to see is we start from an altered situation before surgery, and we want to go back to a very normal situation after surgery. So and this is also an interesting paper which saw that when we do hallux valgus surgery, it's very difficult also to change the kinematics if we compare at a higher level, like in the knee joint, in the hind foot. So we have an altered mobility kinematics in those joints as well, and we want to go back to a normal one. And what we also see is, and I realized it as well, is if we, it's very difficult to go back to a normal motion of the MTP1 joint after surgery. And I realized that with a study we did ourselves that especially plantar flexion is impaired after hallux valgus surgery if you don't do anything. The coronal plane though was corrected in those studies, which is clear because if we do a proper osteotomy, that works. And I think this was a very important paper published by Hans and his group. And they found out that if they start physiotherapy, they can change things for good because you mobilize the joint. And that's what Hans already said. You do an active training of the peroneal muscles because you want to plantar flex your first way. And you also have to train the active plantar flexion of the toe because you want to get the grip of the HFL down on the ground so that there is like a more normal, more physiologic gait pattern. And what they saw is they also saw an improvement, especially underneath the great toe, so that the physiotherapy changed the way people went over this pedobiographic plate. And they did it some right after surgery and some weeks after surgery and another 4 or 6 weeks, if I remember right. And there was a change already within this 4 to 6 weeks after the surgery when they did physiotherapy. So I think this paper definitely emphasizes the need for proper after treatment. And I think especially in athletes, we really have to take care that they do proper training after surgery. This is a paper from 1998, and while already mentioned in 1998, post-operative hallux valgus exercises, and he mentions they should utilize, you can read here, a 4 centimeter, 1 meter strip of an SMAC bandage is utilized for the exercise. So it really describes what people should do. And I think we have forgotten about a little bit of that for the normal patients, but especially adults in athletes, we have to do that. So Wiles already describes what he recommends to the patients to do after surgery. And he already tells the patients to start at week 2 after surgery with passive motion. So now maybe we could discuss it at the end, and who recommends what after surgery. And I definitely think that MIS in the lower race already changed the game. It depends on if MIS will change the game for the also for the bunion surgery. We will see. When should we begin with the physiotherapy? When should we tell the patients to start with active and passive motion? When should we begin with sports? I think literature gives a little hint here. It's normally like 8 to 12 weeks in literature when people begin to run again, do heavy sports. You don't really find any literature recommendations, at least I didn't find any what kind of after treatment athletes need. But I think we should really take care, letting them do physiotherapy as soon as possible. Thank you.
Well, my question now is, when do you start your patients' physiotherapy? Do you do physiotherapy and do you let them In an athlete, do you let them go on the stationary bike at 2 weeks to increase the blood flow or not? Ich höre nichts.
Sorry. The first 2 or 3 weeks until wound healing and the swelling is as low as possible, I recommend to do as less as possible. My experience is if they start too early, they have more swelling, and if they have more swelling in the beginning, they will have longer swelling and they will not fit in a normal shoe after 6 or 7 weeks. So what I do is lymph drainage as soon as possible, and doing active motion first after 3 or 4 weeks. The first 3-4 weeks as less as possible. Only normal weight bearing on a flat foot shoe.
Norman, you have a biker and he needs a bunion surgery. When would you let him go back on the stationary bike?
Well, in women, in female patients after 4 weeks, and in male 6 weeks post-operatively. So, although the fixation with screws might be sufficient, I don't believe that if I go very early on bike with pressures in the forefoot, that they will hold. So, and I say 4 weeks in female patients because we made an unofficial study and we were able to show that women, they heal faster than men. So it's very interesting to look at that. So therefore, female patients are a little bit quicker.
Okay, if they're really aggressive, I have these triathletes, I let them go in their bunion shoes with like less than 100 watts, just cardio at 2 weeks. And the runners, I start at 8 weeks for jogging, but really it takes them, I have 2 cases then with triathletes. They told me it takes 3 months that you go back to normal running training. Norman, can you do your presentation already? Or
the current screen should be freed, because otherwise I cannot. Ich kann meinen Bildschirm nicht freigeben.
Hasi, you have to.
Nein, Peter, du musst. Ja, genau.
Peter.
Genau. I tried again. Hopefully it will work. Very good.
Yes.
Wonderful. I hope now you see my screen, and so okay. I will talk about. It's a little bit strange about talking about rare and atypical forms of traumatic hallux valgus in the athlete, but I will talk a little bit about the causes that may lead to this problem. And there's no true definition, but to my opinion, and this is really a personal opinion, it's the involvement of dynamic and static stabilizers that are related to the function of the MTP1 joint. And they can encompass the capsule, for example, as a so-called turf toe variant. It's not a true turf toe, but a partial variant of it. Then the ligaments, of course, I will point out here for example, the medial collateral ligaments, and the tendons, especially the abductor hallucis tendon, and the bones, of course. So isolated or combined injuries of those structures can lead to destabilization of the MTP1 joint, and it's a different form of instability at the joint, and it can even happen a little bit more proximal. The big challenge in these settings is that most of these injuries, if they happen acutely, they can only be identified under dynamic testing, because the hallux valgus is something that starts to develop during weeks, even months, depending on the structure that is injured. Therefore, most of these lesions in the acute setting will go un- or misdiagnosed, or too late diagnosed. Now let's start. I have, for every type that I found in my Samosurium. Let's start with the first injury and the proximal injury in a soccer play. It's a young man who has got this injury, and you can see on the lateral view a plantar gaping of the TMT1 joint. At the beginning, it was hurting him on the plantar aspect of the TMT1 joint, but he didn't give so many thoughts on this, and over time he developed a hallux valgus deformity, and it was a direct injury to the medial aspect of the foot while dorsiflexing the midfoot and everting it. It's very different to other injuries. So he has had a clinical instability at the TMT1 joint, as we know it, for example, in the hypermobility of the first ray in people who have this, like an inborn variant. And he developed a secondary hallux valgus deformity with the hindfoot valgus, as you can see on the AP view. So this is a secondary forefoot-driven hindfoot valgus, which has been caused traumatically. And this is very interesting to see. I have only maybe 2 or 3 of those patients, maybe because all the others I missed. But this is something interesting. I just tried to figure out what happened. And here in this case, we did the TMT1 fusion and correction of the MTP1 joint in order not only to correct the instability at the first TMT1 joint, but also to create a new force to correct the hindfoot, because the hindfoot went into valgus and the entire rear foot turned into valgus, which could then also harm the medial structures over a longer time. So we did also the correction of the hallux. We added this in order to realign everything. This is a very exceptional problem. Maybe another second example, an injury to the medial capsular ligamentous complex at the MTP1 joint in a 23 years old female jogger. She was jogging a lot, and after some case, she felt pain at the medial MTP1 joint and presented very late with it. And if you look at the X-ray, maybe a little bit hallux valgus, but not that much in the standing view. And it's almost normal X-ray with a little bit of lateralized sesamoids and interphalangeal hallux valgus, but she was very painful on the medial aspect. And during dynamics, when she was walking barefoot, the hallux valgus turned into the greater toe turned into valgus dramatically. And this is something that you can't see on X-rays when they stand in front of you. So it was clinically super unstable. And in the MRI, as you can see on the image on the right side, the medial aspect, there was an avulsion of the abductor hallucis tendon. So she had this injury not only to the abductor, but maybe also to the collateral ligament. This is how it could present the greater toe like this with an effusion, but not in every case. So when we open up this the greater toe joint, you can easily see the avulsion also affecting the plantar plate very close to the medial sesamoid, as you can also see here. And what we did was a distal first metatarsal osteotomy to realign the sesamoids, but also to tether a little bit the abductor hallucis longus, abductor hallucis tendon, so into the proximal phalanx with suture anchors. In the third example, we have a lesion of the plantar medial capsular ligamentous complex at the MTP1 joint in a 49 years old male surfer. He had this injury while surfing. At the end, he had an elevated greater toe, clinically pain at the medial MTP1 aspect, and a dynamically painful hallux valgus during walking. So he was clinically unstable, and what we saw on MRI was the avulsion of the abductor hallucis tendon with a tear of the AFHL, as you can see on this image here, which is very difficult also sometimes to assess in the acute setting because of the swellings. And here are the MRI pictures of the patient, the same patient as we have seen now with the photographs. And you see that there's an avulsion of the entire medial aspect, and this is a variable extent from the medial side onto the plantar plate, involving the sesamoids too. So it's very difficult, although you can have a tender spot. And planning surgically, what we did is, of course, we planned to reinsert everything that was torn off. And we also added an osteotomy in order to realign the first metatarsal. These are the images, as you can see. If we have on the left side, starting with the repair of the abductor and plantar plate medially, We put in some anchors, as you can see on the second slides from the left side, and then reattached the plantar plate together with the abductor tendon and added an osteotomy. It seems always in the X-rays a little bit overcorrected, but this will wear out over time. But the patient has been very happily with this correction. The fourth example, and I don't have images for them, is from taken from directly from the literature by Parekh and Hintermann's group, is the sesamoid fracture. The sesamoid fracture can lead to hallux valgus deformities in the athlete. And as we can see, what they recommend is to, if possible, to fix the sesamoid bone. In addition, you can also add some osteotomies, as for example in this example here by the group with an aching osteotomy. But of course, these fractures to treat are not very easy, I must say. And if it becomes necrotic, maybe you have then to do other stuff than to fix it back where it should, where it was, because then also arthritic changes have taken place. So I think, to my opinion, this is a very, very acute treatment. If you have a lesion of the tibial sesamoid with a rupture of the plantar plate medially and you don't see it and you don't recognize it, the late response of it will be an arthrosis, as you can see. And these arthritic changes in the sesamoidal metatarsal complex are very debilitating. And this is a 46 years old soccer player. 2 years ago, he has this hit. He presented, interestingly, 4 weeks ago in my practice, and as you can see, it's already arthritic, and these cases become very, very difficult, because if you consider to remove the sesamoid, you're also pointing this joint into a hallux valgus deformity if possible. So therefore, I am very reluctant to do anything except adapting the shoe. And then there's a very rare, and by luckily I found this proximal tear-off of the sesamoidal band. This can sometimes happen, and you have to refix it with anchors. These are very difficult to treat because you have to use small anchors. Direct osteosutures are not feasible in this setting because it's too tiny to operate on. I have brought up a little algorithm for myself with pain at the MTP1 joint in the athletes. You can, of course, use the X-ray, and if you see hallux valgus in the static or dynamic, and dynamic is more important because I call it the rollover maneuver. You let the people walk and you see how the degraded toe drifts into valgus. Then you can do the MRI. And I think the MRI here is one of the most important imaging studies that you should use in order to figure out what will be done. You have here all the treatment strategies, starting from the medial capsular injury, avulsion of abductor hallucis, medial plantar plate rupture, tibial sesamoid fracture, then subcapital metatarsal head fracture, which we didn't show here, but of course any subcapital metatarsal head fracture can malalign, then sesamoidal arthrosis and MTP1 arthrosis as a late sequel of these injuries. I think they are very special. You have to think at those, and if you think properly and you stay vigilant to these injuries, then a proper treatment plan can always be tailored to the patient's needs. Thank you very much.
Thank you. Any questions from the panel?
Well, I think yeah, sorry, Waizy?
Yes, thank you.
I think normally you did a fantastic talk, man, because those are really the problems that we find that we don't know what to do with them, especially with the sesamoids and with the fracture of the sesamoids. And I have already done 2 or 3, and honestly, it didn't work. Like fracture fixation, and it's just a big hassle because you just don't find the screw that is good enough, and then honestly it didn't work, and the sesamoidectomy also doesn't work for athletes, I think, as well. So I think
pellet answer
it's very, very difficult thing, and I think you're doing very well with not doing surgery and just trying to give them orthotics or shoe modification or whatever.
If you have to, Norman, if you think that somebody has a medial collateral ligament tear. How do you stabilize it? To tape him for 6-8 weeks? Stiff shoe, or what do you do with them?
Yes, in an acute setting, taping is worthwhile to do, as long as the abductor tendon is not torn off. When the abductor tendon is still in place, but only the medial collateral ligament is lesion, then you can leave it, and I leave it only for 4 weeks, and then I start back again with movements. But the tapings are quite useful, but this is only in the super acute setting, like in the knee. But if it's chronic, or subacute, then it doesn't work. It doesn't work. Then you have to go for an operation.
But I think we can do a few cases, if you like.
Great.
And we start here with the first. This is a soccer player, 28 years old. He had a bunion deformity, which is unusual. And with the soccer shoes, it's very difficult to use them. So he got bursitis. And what do you do as a team doctor if somebody has an inflammation on the foot as a soccer player and a bursitis? You inject cortisone. So then somebody stepped on his foot and he had a cortisone injection. Previously that, and he had a hematoma, which led to this horrible situation. So what would be your options now?
Would first get rid of the infection.
Okay.
First, before I do anything.
So he's 28 years old, so he's going to the end of his career. His range of motion by that time was 30-0-20.
Was the motion painful?
Yes.
How does the joint looks?
The joint was fine.
Okay.
So radiologically, what they did before, they did 2 surgeries before. They did some bunionectomy and some bursitis resection, but then I had him on the OR like this. Look at the right picture. That's what came out when I opened the skin.
Get rid of the infection first. Oh.
Yeah.
Mm-hmm.
Wow.
So see, this was so soft, the bone here.
Yeah.
So infection treatment first.
Yeah, I would go for infection, surgical infection control, and I would do that. Yes, and then depending on the first cleaning, as you did, debridement, and then depending on the resistances, the antibiotic treatment. But usually they can get better, but we'll see.
What's the future of this person?
I would say arthrodesis.
Definitely. Because anyways, I think after the surgery and after the infection, he would get stiff, no?
These were the pictures after I debrided it.
Yeah.
Looks good for what it was.
Could he go back to football afterwards?
Well, he went back to play after 4 weeks.
Wow.
But then 4 months after debridement, he noticed he could not sprint anymore. He could jog, but he was not able to participate in the league games. So what to do now?
I would go for arthrodesis.
How do you think that an arthrodesis for a soccer player will that create problems for him?
No, they work well. We did a study with those, and we have some soccer players, professionals, with a fusion of the first MTP1 joint, and they do well, better than one would imagine. Better.
Yeah. So that was, we started to do the surgery. We fused him.
Good.
That was the function of his 5 years after surgery. And when I do my fusions, on the table, I looked at he can create pressure with the tip of his big toe on the ground. Especially for the athletes, this is very important. Not too much dose if they need to do things. And there were two studies. This one study on the function of the arthrodesis using the screws. The question is, were those real athletes? So 12 of the 16 came back to running, they came back to tennis and everything. So that looks good. And another study here by Nunley. So they had here 4 top athletes doing an MTP fusion. 2 were NFL players, 1 NBA players, 1 European soccer player, and they did really well.
I think especially the runnings, they are better than the datas.
Yes. So I had one runner who did a half marathon after the MTP fusion in 1:20. And I said, why don't I get a fusion on my MTP one? So that was the career of this player afterwards. So in 2001, he did 3 games and he had the surgery. He went back to play. He said he's a defense and he was the captain of the team. So he scored in the years afterwards, doing 20 to 28 games, and he entered the Austrian national soccer team after the fusion. So it's not the end of a career if you have a athlete who has to get an MTP1 fusion.
Hans, we have one quick question before we wrap up.
Yes.
For the panelists. If you have a patient who has medial sesamoid arthrosis in the setting of a bunion, how do you handle that?
I leave it. I don't, because if you correct it, then if you correct the bunion, also with the sesamoidal position will be changed. And I then wait and see.
Same me. Sometimes I go for osteophytes and resect the osteophytes, but I try to don't resect it in one setting.
I believe the same. And my partner, Dr. Christen, did a study. They looked on the arthritis changes of the sesamoids in their bunion cases. And I think 80% of the bunion patients had arthritis in the sesamoid groove. And they never resected the sesamoids. The patients had no problems afterwards.
All right. Well, excellent. Guys, this was a fantastic session. I appreciate your time and insight and expertise. I thank Novastep for sponsoring this hour, and we'll see everybody in about a minute.
Thank you very much.
Thank you.
Thank you.